Hello, welcome to Unit 3 video lectures. Talking about Chapter 21 first. It's all about assessment of cardiovascular function. So, A&P review, big things. The heart's got three main layers. Its outside layer is really comprised of two separate layers that make the pericardial sac. Basically, the pericardium is the sac around the heart. And remember that a lot of our organs have double-walled sacs. They're really that organs that move a lot, like lungs have the pleura. Our whole abdomen has the peritoneum. So a lot of the stuff around here is going to so for movement. So pericardium, technically the outside layer is the epicardium, but it's part of that visceral part, the part of that touches the heart of the pericardium. Then you have the myocardium, which is the biggest, most important part, the muscle of the heart, which is majority of what it is. And then the inside of the heart chambers are surrounded by endocardium, which is very like single cell, very smooth, which makes sense. You don't want a rough inside if you're pumping blood. You want blood to move through there smoothly and red blood cells not to get damaged. For anatomy, just make sure you know kind of the rules of four is what I usually talk about. So the rule of four is there's four chambers, four valves, four arteries. So you have your right atrium, right ventricle, uh, left atrium, left ventricle. You have your over here, this valve between the right atrium and the right ventricle is the tricuspid valve. The valve that's between the left atrium and the left ventricle is the mitral valve, sometimes called the bicuspid. And then you have two valves and valves again prevent backflow. You have two valves leaving the heart, one going to the lungs through the pulmonary artery, so pulmonic valve, and then one leaving the heart from the left side to the aorta here to go to the rest of the body, part of systemic flow. That's the aortic valve, which are fairly easy. And the valves closing, when they close shut, that's making your heart sound, what's known as the lub dub or S1 and S2. So dum 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 dum. The valves closing is what makes that heart sound. The role of valves again really is prevent backflow. Any valve in the body is preventing backflow. That's their job. So when blood flows through these areas, the valve will snap shut based on the pressure changes in the heart as it pumps, and they should shut fully. And again, they're responsible for preventing backflow, and they're what produces our heart sound that we hear, the lub dub. Um, So more stuff, blood supply to the heart, cardiac conduction system. Blood supply to the heart is known as the coronary circulation. You can see that this is part of systemic circulation. Blood is leaving the aorta and branching off in these multiple arteries called a coronary circulation. Coronary is kind of the same word for coronation or coronary means like crown. So coronation means crowning. Coronary is like the crown of the heart. It surrounds the heart on kind of the most superior surface. And this is where heart attacks come into play, coronary circulation. If any of the blood flows cut off to these coronary arteries, then it causes myocardium ischemia, tissue damage. There you go. There's your heart attack. The other thing over here is the cardiac conduction system. Remember that the heart muscle has these nodes, they call them, of pacemaker cells. These pacemaker cells elicit changes in electrolytes that trigger an electrical response, basically separate from our own nervous system. And they send this response at the same rate every time to produce a heartbeat that's 60 beats, 60 to, 100 beats or 60 to 80 beats per minute. And know the pathway. You want to know the pathway. This is anatomy. You got to know this, but SA node signal travels down to what they call the AV node. Then that signal travels through the bundle branch, or also known as the bundle of His first, this big lump bundle coming from the atria. And then it goes through the septum, the big dividing line between the ventricles. That is the uh, bundle branches, and then it branches off into small fibers that go throughout the ventricles known as Purkinje fibers. And the pathway of this electrical signal is what makes the heart beat. So the heart can beat independently of the nervous system. Of course, the nervous system influences the heartbeat greatly. Tachycardia, bradycardia, make it low, high, that sort of stuff. But the heart can beat on its own. So P wave QRS complex, what is this? So you want to kind of have a general idea. You need to be able to, if you looked at the study guide, you need to make sure and be able to define these. So be able to define what the P wave is, define a T wave, and kind of talk about what some of these concepts mean. So, excuse me, the P wave is atrial depolarization. And so let me define depolarization, repolarization. So depolarization is a change within the cell, basically, during which the cell undergoes that shift in electrical charge, and then that signal gets distributed along a pathway, the nodes, basically resulting in kind of a negative charge in the cell. And this makes the cell contract. When muscle changes charge, it contracts. So depolarization basically, just for layman's term, just think of it as muscle contraction. Repolarization is the membrane potential of that cell. The electrolytes move back to their resting potential. And basically what's called an action potential has already gone through and changed, and now the cells return to their resting state of kind of being more positive with their electrical balance. And this repolarization I always remember as relax. Basically, repolarization means the muscle relaxes. So P wave represents atrial depolarization. So the atria contracting, this transition between the signal on the SA node to the AV node. That's the atrial depolarization, the atria doing their small contraction. That's why it's a smaller blip. The QRS complex here, this whole structure, is representing ventricular depolarization. So the ventricles, both ventricles contracting, the movement of the signal through the septum and then Purkinje fibers, this big, huge waveform on what an ECG measures, or an EKG. An ECG is this, it is measuring these electrical signals. And so it is measuring basically the blips or the changes in the contraction of the heart muscle, and that will show as an electrical waveform. And that's what we're seeing. So it's an electrical waveform is what ECGs are showing. And then you don't see it, but there is a atrial repolarization or relaxing, but it's a very, very small blip, and you don't usually see it because it's hidden by the QRS complex. And then the T wave is the ventricular repolarization. So the relaxing, that movement back to a resting potential causes a small spike in electrical current, and that's where you see the T wave. So you want to be able to define these. You also want to be able to define the PQ and ST segments, or PQ interval. PQ is basically just talking about what's the time it takes in seconds to move from the atria contracting to the ventricles contracting, basically, because Q is kind of the start of that electrical change that causes the ventricles to contract. ST segment basically talks about what's the time between the ventricles contracting and then relaxing. And if these are elongated, these time frames are elongated than more than normal, then that could kind of indicate some cardiac dysfunction, muscle injury, or dysrhythmias, issues with the electrical impulse of the heart. Okay, let's see here. So this is a video from one of my favorites, Nurse Sarah, but she does a good job explaining everything. So I'll kind of let this play out.
Hey everyone, it's Sarah with registerednursern.com, and in this video I want to be reviewing the parts of the ECG waveform. So let's get started. So first, let's look at the P wave. The P wave represents atrial depolarization. So this leads to the contraction of the atria, which is created by the SA node. So whenever those atria contract, it creates this little wave. Now right after the P wave and before the QRS complex, we can find the PR segment. And the PR segment demonstrates the delay the AV node created. Remember, it was the gatekeeper, so it gave the atria time to dump its blood into the ventricles before the ventricles contracted. Also found in this area is the PR interval, and I really want you to remember the PR interval because we measure this, and it's very important in determining if your patient has a heart block. So the PR interval starts at the beginning of the P wave and extends to the beginning of the QRS complex. So it's different than the PR segment. The PR segment was after the P wave. The PR interval is before the P wave to the beginning of the QRS complex. And this demonstrates the amount of time it takes for the electrical signal to go from the atria to the AV node. And if it's taking too long, if we have a long PR interval, this could indicate a heart block. Next is the QRS interval, or also known as the QRS complex, and this represents ventricular depolarization. So this is leading to the contraction of the ventricles. Also found in this, but you can't see it, is atrial repolarization, where the atria are relaxing, but the ventricles are so large that whenever the atria relax, it's overshadowed by the ventricles, so you're really only seeing ventricle depolarization here. Then we have the J point, and this is the point where the QRS complex meets the ST segment, and the ST segment represents the completion of ventricular depolarization and the beginning of ventricular repolarization. And this segment should be flat, hence it should be isoelectric, meaning flat. So there should be no depression of it or elevation. And isoelectric is a word that is used to describe straight across lines of the PQRST complex that represents that the heart cells are resting. They're not contracting and causing electrical activity, so none's being transmitted to the EKG. Then here we have the T wave. The T wave represents the beginning of ventricular repolarization, so relaxation. And the ventricles are so big that whenever they relax, it creates this T wave. And then after the T wave, you usually have a flat line, which is representing ventricular repolarization is complete. It's a flat line, isoelectric. And then the cycle starts immediately again, where you get a new P wave, QRS complex, T wave, and it just keeps going on. Now, sometimes after the T wave, you may see a U wave. It's not the case in a lot of patients, but in some patients, and it may be happening because your patient's potassium level's low, like in hypokalemia. And then lastly, here is the QT interval. The QT interval starts at the beginning of the QRS complex and ends after the T wave. And this demonstrates the time it takes for electrical signals to cause the ventricles to contract and then rest. So now let's recap all that information and look at this PQRST complex and see how depolarization and repolarization is occurring in each part of that complex. So here, section 1 is the P wave. That represents atrial depolarization beginning, so we have the contraction of the atria. Then 2, that was our PR segment. That was atrial depolarization complete, so it's done. Then 3 was our QRS complex, and it represented ventricular depolarization beginning, and in there, but you can't really see it, is atria repolarization. It's relaxing. Then 4 is our ST segment, and that is ventricular depolarization completing. Then we have 5, which represented our T wave, and that is ventricular repolarization beginning. And then 6 is that flat isoelectric line, and this is ventricular repolarization complete. Okay, so that wraps up this video, and if you'd like to watch more videos on ECG interpretation, you can access the link in the YouTube description below.
Okay, so from that, what can we infer? What is the QT interval on an ECG? What is it measuring? So I'll give you a second to answer or to think about it. Again, with these, just pause the video is the easiest way so I can save time, right? So just pause video, see if you can figure out the right answer. If you pick number 3, you're correct. Basically, the time it takes from the ventricles to start depolarizing, to start contracting, and then the time it takes for the ventricles to repolarize at the end of the T wave. So cardiac output is another kind of AMP patho reference that you need to kind of know. Cardiac output, what is it measuring? So this is the total amount of blood that's ejected from one ventricle in 1 minute, basically. Over a whole 60 seconds, how much blood gets ejected from the heart. In theory, our cardiac output should be somewhere in the neighborhood of 5 to 6 liters. It should be our whole blood supply. Everyone should have around 5 to 6 liters of blood. And it might be our whole blood supply and a little extra is traditionally what cardiac output should be. Stroke volume, SV, is the amount of blood ejected from one ventricle per each heartbeat. And then heart rate, of course, is how many times our heart beats in a minute, which could be affected by our hormones, affected by our nervous system. But the cardiac output formula is basically taking that stroke volume, the amount of blood ejected from the ventricle from each heartbeat, which is around 50 to 100 milliliters, depending on the person. And our heart rate range should be 60 beats per minute to 100, but taking the stroke volume multiplied by the heart rate will give you cardiac output. The defining factor here for you guys really is think about how you could use this as far as like assessing a patient, right? So if you know, right, a patient has had a lot of blood loss and is super anemic. So what's low here? Well, that would be their stroke volume, right? Their stroke volume is low because they have lost a lot of blood. So probably the amount of blood that they're actually pumping is going to be on the lower end, the volume for their stroke volume. Which what's that going to do? Our body wants to always keep the cardiac output at a certain level. It's part of homeostasis. So then our body slowly starts to raise the heart rate to kind of compensate, right? If we had too much fluid, we might lower the heart rate to kind of compensate. That's more uncommon, but you kind of see the gist. And so this formula is not necessarily like a math formula. It's more about kind of a thought process about your patient and what symptoms would or what manifestations you might see depending on the reason. They have too little, too much stroke volume, too low of a heart rate means it doesn't matter how much blood I have, my cardiac output is affected, and eventually bradycardia can lead to, cardiac arrest and stuff because of decrease in cardiac output or kidney failure, all the stuff. So stroke volume, again, factors that affect stroke volume, some of the more specific stuff is something we talk about: preload, afterload, and also contractility. So these are need to know. So this is a nice little picture about it. But what preload is talking about, mainly think of preload as how much stretching do the muscle fibers in the ventricle do. So the more stretch, the more they balloon out. The ventricles, the more they balloon out and fill with blood, the more blood they can move. So that's preload. Afterload, on the other hand, is basically the ability of the myocardium to contract normally, or excuse me, that's contractility. Sorry. Contractility is the ability of the myocardium to contract normally. So things that affect contractility could be heart failure, but usually preload, afterload are causes of heart failure. Contractility is talking about heart failure or heart attack that damages the muscle. How contractible is it? Afterload talks about basically the pressure in the ventricle muscle must overcome to generate the pressure it needs to shoot blood through the aorta. The left ventricle mostly is talking about afterload, the blood we need to get out of the so kind of think of it as a balloon. Like the preload is if I inflate the balloon with air, that's the muscle stretching. The afterload is the balloon's filled with air and I tie it in a knot. That's the resistance. So it takes a certain amount of force to pop that balloon because it's tied off and that pressure has to increase. So that's what afterload is how much pressure and force does the heart need to overcome to force the blood out during a contraction. Overall, if the afterloads increase, for examples, high blood pressure, vasoconstriction, peripheral resistance, so atherosclerosis, arteriosclerosis, those kind of things increase afterload and make the heart work harder. So which of the following options describe preload? So which one of these describe preload? Again, pause the video, take your time. You'd answer the degree of stretching at the end of the diastole. So again, diastole, systole. Systole is the contraction part. Diastole is the filling of the heart. And mostly we're always talking about the ventricles because they're the true workhorses. They're the true movement of blood comes from them. That's preload. Directly, resistance in the ventricles need to overcome during ventral contraction. Number 4 is the definition really of afterload. So heart rate, how do we control that? We control that, again, autonomically by the pacemaker cells, but our nervous system has a huge effect on it. So sympathetic nervous system, if you remember a little bit about neuro, there's sympathetic and parasympathetic. They are part of our autonomic nervous system. Sympathetic is all about the fight or flight response. So either we're fighting or we're running or whatever, we're increasing heart rate, increased stress. That increases the force of contraction. The catecholamines, the norepinephrine, epinephrine of the adrenal medulla, the adrenaline drugs, basically, as you call adrenaline. Parasympathetic is what's in charge most of the time. This is decreasing heart rate and decreasing force of contraction, relaxation. Parasympathetic, called rest and digest. Sympathetic, I refer to as fight or flight. Other differences that are specific to gender: women tend to have physically a smaller heart. They also tend to have a little bit less blood volume. Women's arteries are slightly narrow, and women develop coronary artery disease later than men. They usually develop it later in life. Health history. So the need to know here is modifiable versus non-modifiable risk factors, and this is highlighted in the study guide. These are what is the risk factor for developing coronary artery disease and developing high blood pressure as well, really. But it takes past medical history, definitely a history of family issues of cardiac disease. It's always a highlight. But some examples, right? Modifiable means something that you can change. I can change my weight. I can change how much I exercise a week. I can change my diet. I can change what I eat. I can lower my intake of high sodium foods and high fat foods. Um, those kind of things I can't change. How old I am. I can't change my race or ethnicity. I can't change genetic history. Those kind of things are non-modifiable risk factors. You need to know the difference between those. You need to know those. So cardiac symptoms. So what's some examples of cardiac symptoms? Just think of them out loud. You've hopefully read through the stuff. We talked through this stuff, but chest pain, obviously, right? Shortness of breath or dyspnea, fatigue in general, just malaise and fatigue, palpitations. Palpitations are feeling like the heart's fluttering or you feel your heart beating in your chest oddly. That's palpitations. Syncope, dizziness, much more common in women. Fluid shifting for heart stuff. So edema, cough associated with the dyspnea, and just general like feeling of doom or anxiety. Vascular symptoms. So vascular symptoms are much more specific or focal or local sometimes, but they definitely would include edema, excuse me. But a lot of it's going to be like development of lesions on the extremities, paresthesia or sensation changes. Paresthesia is the numbness, kind of tingling sensation, discoloration of the skin, just general pain in the extremities. So objectively, what are we looking at? You've done this sort of stuff with your health exam for physical assessment class and stuff like that. But the chest shape and contour, mental status changes, level of consciousness, those kind of things. Vital sign changes. What does the heart sound like? Is there an S1, S2 present? Is the rhythm regular? Skin color too, pallor, rubor, cyanosis, bruising, mottled. Those are interesting. So rubor is like this extreme redness. So I always remember rubor is like this extreme redness because rubor starts with R. So rubor. It's kind of like rhubarb. I say rhubarb, but it's like rubor. Cyanosis we know is like the blue tinge to lips and extremities, fingernails. Blotchy bruising, sign of wounds. This is something called Raynaud's syndrome here. Also modeling. If you want to know what modeling is, I would say that's a need to know. But this on the far right here is modeling. Modeling is like this. Basically, you would call it a blotchy, purple redness marbling rash, like marble. Usually this is seen in the last days of life. So you don't see this usually on patients that have already been deceased or patients that are on their way out the door to visit the good Lord. Unfortunately, this is usually something that shouldn't be seen. Mainly why this is happening is this is basically blood is shunting to in death, blood will start to shunt to all the vital organs, and the skin and the periphery are the first to kind of lose that blood flow. Other physical exams, jugular vein distension. This is an image showing it, but we use that assessment tool for them we shine our light and have them turn their head. And if their jugular veins are distended, this is an indication of massive like preload problems with overfluid. Usually this is more jugular vein distension is definitely more in the fluid overload symptom. Clubbing is the change of the nail beds and the fingertips to look like a club. That's essentially always going to indicate chronic levels of hypoxia. You'll see that in cardiac patients. You'll see it in chronic lung patients. Capillary refill could be diminished. And then other peripheral pulse changes, bruit, thrills, rating. So bruit, the BRUITS, bruit is spelled bruit, but it's pronounced bruit. Is an audible like vascular sound that's heard with turbulent blood flow in an artery. Usually bruits are more aligned with incompetent valves or valves that aren't working. Thrills are vibration sensation over the area of the blood turbulence. So usually bruit and thrill are like happening together. You'll hear a bruit, this weird kind of extra thrashing sound of turbulent blood flow, and then you could put your hand there and you'll feel the thrill. And the rating is like, how strong is it? Is it minimal, hard to find, 1+, 2+? Is it normal, 3+? That sort of stuff. And then pulses, yeah, again, most scales people use usually 1 through 4. Some are 1 through 3, but usually they're 1 through 4. So again, 1 is like weak, or what people call thready, hard to find, very, very weak to feel on palpation. It depends on the scale. 2+, 3+ could be normal, strong. 4+ would be like bounding, like almost the vein, almost like it's pulsating out of the skin, that sort of stuff. And then auscultation of heart sounds. You guys know this, but you're listening for the S1 and S2. That's the lub dub sound of the valves shutting close, right? So S1 is the tricuspid and mitral valves closing. So S1 is the sound of those valves snapping shut, the valves between the atria and the ventricles. As the ventricles start to contract. S2 is closure of the pulmonic and aortic valves, and that would be at the diastolic end of contraction of the ventricles. So S1, S2 is those sounds of them closing. S3, S4 are considered kind of abnormal. S3 is abnormal in older adults, but sometimes you'll hear S3 in children. And then S4 is always kind of significantly talked about as an abnormal sound, like the heart not pumping effectively, extra heart sound, something like that. But you should, S1, S2 is the gold standard. Heart murmur is basically means an extra heart sound created by turbulent blood flow. Usually heart murmurs are ineffective or in either valve stenosis or valve regurgitation. Some kind of valve issues when you hear a murmur. And they can be fairly benign, and people can have them all their lives. It depends on what other symptoms it may be causing. Friction rubs are basically related to edema and inflammation around the pericardium, and that would create a harsh kind of sliding, grating sound. And this is inflamed pericardium. The 2 layers are rubbing together, and they shouldn't be. There should be fluid in between them, and 2 layers of the pericardium shouldn't be touching. Thing to kind of think about is all physicians take money. So those are the 4 places you're listening for the valves. Kind of around second intercostal, left and right for aortic and pulmonic, around the 4th intercostal for tricuspid, and 5th intercostal midclavicular line for mitral valve, which is also known as the apical pulse. There's another point in there, Erb's point, that's around 3rd intercostal in line with these 2. Assessing edema, pretty simple. It's really just poking your finger in someone's skin. Edema can add, even just 2+ edema generalized on like the extremities could add up to 10 pounds of fluid. So when people have edema, there's definitely fluid involved there. So the need to know there is when we talk about, especially when we talk about heart failure and patients that suffer from fluid shifts, the biggest, easiest way for people with fluid shift problems, especially in heart failure, to know that they're having a problem is if their daily weight changes. So daily weights, especially for the heart failure patients who are worried about fluid overload and fluid shifting, is going to be the best way to tell someone that something's happening, because fluid weighs a lot. And so daily weights will tell us if that's changing. Other diagnostic tools, a complete blood count, chemistry, so basic metabolic panel that looks at glucose and electrolytes, BU and creatinine, because if blood flow is affected, the kidneys are one of the first organs to get affected by that. Kidneys need a lot of blood flow. Lipid panels looking at cholesterol levels overall, triglycerides, HDL, and LDL. So always want to know these. This is good and bad cholesterol. Cholesterol's job is more about transportation of proteins in and out of cells. Same thing with kind of triglycerides, are basically free what they call fatty acids. It's type of glucose that's stored in adipose tissue as a source of energy. So that triglycerides shouldn't be too high in the blood. HDL and LDL are about transportation of proteins. They're fat molecules that transport proteins. So like a amino acid protein combo. And for LDL is considered the bad cholesterol. You want LDL lower, and HDL is considered the good cholesterol because it carries the proteins into the cell, so it doesn't spend as much time in the bloodstream. So having HDL higher, they kind of have an inverse relationship. So if HDL is higher, I'm happy, because it's the good cholesterol. Other labs, CK, creatinine kinase, also specifically cardiac is CKMB. Usually this level should be 0. If this is elevated, it kind of means cardiac injury. Same thing with troponin. Troponin should be less than 0.4, 0.5, usually 0.4. If that shows up, usually takes a few hours for troponin to elevate, somewhere in the peak of like 24 hours. Maybe 6 hours to appear. Is a little slower to appear usually. I'm saying the opposite. Usually shows up some of the fastest, but what I mean to say with troponin is it stays the longest. It can stay up to 7 days plus. Basically, a troponin could be elevated after a cardiac injury over a couple weeks. Another option is myoglobin. So the big three is CK, and CKMB is a subtype of CK, creatinine kinase. Troponin, myoglobin. Your biggest one that always gets ruled out is troponin, though. Troponin is going to be your biggest one. C-reactive protein is all about inflammation. It should be less than 1 milligram per deciliter. Some other stuff related to peripheral blood flow and just general things is PT and INR. PT and INR are measuring just the time it takes for a blood to clot. INR should be around 2 to 3.5. INR is associated with a medication called warfarin, Coumadin. You want to kind of know that. Hopefully, you've heard of warfarin or Coumadin. Warfarin or Coumadin is one of the old school blood thinners. Its goal is to again thin blood, quote unquote, but basically delay clotting time. And the antidote for warfarin is known as vitamin K. Vitamin K kind of counteracts warfarin because warfarin's direct MOA, its method of action, is to affect the liver's production of vitamin K, which slows down our clotting ability. That's direct warfarin's direct thing. PTT is more associated with general heparin therapy, and we try to make it therapeutic. So we're generally looking for a higher PTT because PTT is basically a time measurement in seconds of how long it takes for a body to clot. And we want PTT to be a little bit elevated, slower to clot if that's what we're trying to treat. And then overall, don't forget platelets, also known as thrombocytes. We want a decent amount of those guys. Platelets should be anywhere from 150,000 to 450,000. And so if platelets are less than 150,000, then you start to go, okay, so risk of bleeding is now increased. Other stuff, ABGs can be helpful when there's other conditions causing cardiac disruption. Drug levels for cardiac meds like digoxin. One to highlight here is BNP. BNP is a natriuretic peptide hormone, or a measurement of this. This hormone is released by the atria of the heart, actually a goal to decrease blood pressure. So a derivative of ANP, atrial natriuretic peptide, is called BNP. So it's a derivative of that hormone made by the atria. And it's if this is elevated, it usually indicates congestive heart failure. Basically, if this is elevated, this BNP lab result, it indicates heart failure typically and increased stress on the cardiac muscle. Other things we're doing for testing, obviously, we can always do a chest x-ray to visualize the heart, see the heart shape, if it's enlarged. Gold standard is going to be an EKG or an ECG, usually the 12 lead, the big guy, and that's what the ERs do. We could put people on monitoring. Continuous monitoring is usually done by a telemetry monitor or a home monitor called a Holter monitor. And then we can do more testing with a exercise stress test. Echocardiogram is looking at the heart with an ultrasound machine. We can do CTs and MRIs of the heart. And this is a 12-lead EKG. Chest x-ray, again, shows the size of the heart. This is in a large heart in a patient. This is showing a Holter monitor. Fluoroscopy is a scope within dye. So stress test, this is neat to know. Make sure you know kind of what a stress test is. So a stress test is a physical, or it can be chemically induced, but in the physical, it's used to help diagnose and the degree and severity of cardiac coronary circulation blockages. So if a patient develops they're having cardiac issues with angina, with chest pain, we want to kind of rule some stuff out and see what it is. And we know that chest pain is induced by depriving the cardiac muscle of oxygen. And the best way to test that is exercise. So an exercise test will get you on the treadmill, read blood pressure, have you on cardiac monitoring. If you start getting significant changes in vital signs, and then of course, if the patient goes into full blown, I'm having chest pain, I'm having cardiac symptoms, like diaphoresis, sweating, pallor, dizziness, and chest is hurting, we're going to stop the test, right? We're not going to let them pass out on us. But overall, the goal is to get their heart rate to a certain level and see how their cardiac function is. If it stays stable, then we kind of rule out that there's any coronary blockages, and whatever their chest pain was initially or their symptoms related to or doing this test, we might work up another route. The goal is to get the heart rate to what they call the predictive maximum for the age with no signs of angina or chest pain. And it can be done chemically for patients that can't walk or can't exercise to that ability, but they try to avoid that if they can for stress testing. So, question here. So during exercise stress tests, when would you stop, or when would the test be stopped? When would I stop this test? If you answer when the client experiences chest pain or discomfort, that would be the right way to go. Again, the goal is for the client to reach their predicted maximum for their heart age, but then we want to like let them go a little past that. Client's blood pressure drops significantly. That's not uncommon, but how far are we dropping? We don't know. There's not a lot of details there. The client is unable to reach their predicted heart rate. We necessarily don't want to stop it depending on how the patient's doing. This is talking about what the patient's doing. That's the right answer. Echocardiograms, again, are basically ultrasounds looking at the heart. You can tell a lot about the heart structure. You can tell valve issues. You can tell stroke volume from this. If it's really, really important to get imaging that's most accurate, we can do a TEE, put the patient to sleep, and do a transesophageal echo. So we go through the esophagus and basically echo the heart from the posterior side. More advanced, obviously more invasive, but better imaging. And you can do MRIs and CTs. Obviously, they're expensive, and it depends on the situation. Other things to talk about: invasive procedures, cardiac cath, also called PCI. PCI stands for percutaneous coronary intervention. But a cardiac cath can be used as a diagnostic tool sometimes in lieu of a stress test or inability to perform a stress test. So the things to think about is that we're inserting a catheter into a large vein or artery, typically the femoral artery, and running that catheter towards the heart, and then injecting a dye to physically visualize with imaging all the coronary circulation and see if there's blockages. Pre-op is to think about, medication wise, patient typically would continue to take their medication, but they'd have to consult their doctor. Typically, for going back to that for a stress test, typically we don't ask the patients to take any medication that affects their blood pressure before stress test. Let me make that point again. Before a stress test, typically we don't want people taking their normal medication that would alter their cardiac rhythm, because that's going to affect the stress test. Here, you would take your normal medication for the most part, unless directed by the doctor not to. So pre-op, besides that, also just NPO for 8 to 12 hours because we'll be laying flat, that sort of stuff. Post-op, the big things are to observe wherever they insert the catheter, if that was in the femoral artery, or they have the ability to go through the radial artery now with a device that closes it and holds pressure called a TR band. But the biggest thing is observe the site for bleeding. If there's oozing blood or swelling, that's indication of a hematoma and that the artery is still actively actually bleeding, and that could be a big problem. Also, I would throw in there intractable pain. I mean, pain that doesn't respond to medications. That was how I diagnosed an artery bleed on a patient post-cath one time, was that she was having super increased pain to that site in her leg, which it shouldn't be that painful. It should be a little sore, but it should not be excruciating. And there wasn't too many signs of obvious hematoma development or obvious bleeding. The bleeding wasn't happening on the dressing, anything like that. But and it wasn't a palpable hematoma really, more than you would think. It wasn't very obvious, and so caught that one. And I'm always happy about catches, but I caught that one because of the intractable pain. I said, this shouldn't be this much pain. It should be right tender to touch and a little sore, but it shouldn't be like pain meds aren't working. It's miserable. So called the cath lab. They ended up taking her back, and she was bleeding, so they had to go back in and kind of fix that. So something to always think about: intractable pain, bleeding, oozing around this dressing site, hematoma development, so blood pooling under the skin causing swelling. Those are all indications of alarm bells. And we want to check their peripheral pulse on the extremity that they use to access the artery. Usually like every 15 minutes the first hour, then every 30 minutes for an hour, and every Q4 until they kind of discharge. And look at that extremity as well, evaluating for color, cap refill. They need to be on cardiac monitoring. Another big thing with this is because, especially if they go in the femoral artery with a cath, they can't get up and walk around like immediately. They need to usually be on bed rest and lay flat, depending on the provider and how they do the cath. It would be 2 to 6 hours, typically 2 to 6 hours. And make sure the patient gets home with like a lot of teaching, teaching about reporting chest pain, encourage a lot of fluid intake. You'd want them to be hydrated after this. So which of the following interventions is appropriate for a cardiac patient in the post-operative period? Select all that apply. So I'll give you a second to look over these again. Pause the video if you want to answer these. Okay. So 1, 2, 4, and 5. We don't want to restrict their fluid. We definitely don't want them removing their dressing after the procedure. That needs to stay on for a while. It's usually a highly held pressure dressing. And also, if someone started bleeding, obviously, like blood very much coming out and oozing, what else do you think you do for this patient? You would apply direct pressure. In a cath lab situation, we're talking about an artery that was accessed. Arteries are high pressure. If that is bleeding, you need to run in there and hold pressure. I hope y'all are listening to this. Hold pressure firmly on that site and call for help. Initiate the assistance, alert rapid response or code, whatever you got to do to get people in there. So, whoops, number 1 shouldn't have been correct. We don't want them resuming normal activities immediately. Whoops, sorry guys, missed that one. But we do want to do peripheral pulse assessments. We're going to be monitoring their rhythm, their vital signs, and we're going to restrict them to bed rest. They can't move that extremity for a few hours after the procedure so that the artery will heal. Number 1 is not correct. Sorry, I don't know what that was about, but yeah. And this just kind of shows cardiac cath with the cath in place and them injecting the dye, kind of where they go to get there. Very interesting, but this is a little bit more detailed than we need, for sure. This is showing a TR band. TR bands are pretty neat. TR bands are basically, if we go in the radial artery, they do this little band where there's an air in it and they can blow the air up to hold pressure on the wound for a certain amount of time. And then you slowly let the air out as the artery starts to heal. So it's very interesting. And then because it's a clear band, you can see the incision site and you can see the wound. If it starts to bleed after you start letting pressure out, then you should leave the pressure in, kind of thing. Here's some need to know about hemodynamic monitoring. Hemodynamic is talking mainly about blood pressure and just general cardiovascular monitoring. So the need to know here is kind of what are some of these devices. So an ART line is known as an arterial line, is placed in an artery. And this is without a doubt, an ART line is the most accurate way to get a blood pressure. You can put a blood pressure cuff on anything you want, but if you want an accurate blood pressure, you got to go with an arterial line. What the arterial line mostly focuses on is, yes, the blood pressure, but we focus on the MAP here. And this is the thing in parentheses. MAP is mean arterial pressure. This is the best indicator for blood pressure range. And we want this somewhere between 70 and 100 is the MAP range we want. MAP is the best indicator for blood pressure that we're getting an effective cardiac output. A CVP is a central venous pressure monitoring. CVP monitors pressure in the vena cava or in the right atrium. And so that should be around 2 to 8 millimeters of mercury for pressure because it's low. The pressure in the vena cava is the lowest it is in the whole vascular system. So like things like hypovolemia, so too much fluid volume with like right side heart failure is going to cause the pressure to be much higher, maybe 6, 8 and higher CVP. A low pressure, like 0 millimeters reading to 2 millimeters is indicating hypovolemia. So dehydration, blood loss, vomiting, dehydration, I said dehydration twice. Dehydration, hypovolemia would be a low pressure here. Over high pressure is like right side of heart failure and fluid overload. So again, arterial line placed in the radial artery, usually hooked up to a pressure bag to kind of maintain the site and keep it the pressure at the site a certain specific, so that there's no bleeding, and we want to keep the map between, like, again, 70 to 90 basically, or 70 to 100. Another device that's interesting to make a note of is for critically ill patients that need extreme hemodynamic assessment monitoring. Like, the most detailed hemodynamic monitoring we can do is the Swan catheter, Swan-Ganz catheter. Basically, what it does is it measures the CVP. It looks at stuff in the right atrium, right ventricle, and the pulmonary artery. It runs through the right atrium or ventricle and up into the pulmonary artery, and it gives us the most detailed information about pressures, CVP, all that sort of stuff. Very much for critically ill patients. Which of the following are symptoms of cardiac dysfunction? So I'll give you a second to pause. This is a select all that apply. Okay, let's see what you said. So yeah, syncope, cough, shortness of breath, dyspnea, kind of in the same vein. Chest pain, obviously, anxiety. Typically, you don't see muscle weakness. You don't see headache. You can. Typically, you don't see headache or blurred vision with this. You see dizziness, shortness of breath because of trying to increase oxygenation to the heart tissue, dizziness, and general feeling of like doom and anxiety. So that wraps it up for chapter 21. Next, we're going to move on to chapter 22 and kind of continue through this stuff.